At the outset, I would like to thank Amravati team for conducting such a wonderful conference and inviting us here. Thank you so much. So my topic today is Journey of a Sperm, Do's and Don'ts. I think as we have progressed in the cinema today from mute to a black and white to a technicolor cinema to 3D to 5D now, so has the sperm as well. It has also embarked and traversed a journey long enough from where it has got its separate identity from the semen. Initially, the sperm was either present or absent in the semen. That was just the diagnosis. Then it came down to diagnosing it as sterility, then it became infertility, and now finally the term subfertility is being used. Just going back to the basics a little, like where does the semen production basically comes from? As you see that majority, that is 50% of the volume, comes from the seminal vesicles, and hence we test for fructose. When the fructose is absent, you know that there's some problem with the seminal vesicles. The rest 40% are prostatic secretions. The bulbourethral glands add mucus to them, and in the testes, the basic production of spermatozoa happens. So coming down to basics of semen analysis, it starts with collection. I think a semen collection is the most important part for any analysis. It should be done in a relaxed condition for the male partner. There should be a proper hand wash, abstinence of at least 2 to 3 days. In a wide-mouthed container, there should be no condom collection. Preferably, the collection should be in the lab only. In case it is a home collection, always take a consent. So what do you do once the semen is in the lab? What do you look for? We generally look for physical characteristics like volume, which should be more than 1.5 ml. The color should be grey-white. The viscosity, which is indicated by liquefaction. The semen generally liquefies within 30 minutes. In case it is taking longer, so you suspect some problem. So what do you do when there is no semen in the lab? That is when there is no collection. First of all, there are two things that needs to be ruled out. One is erectile dysfunction. You just have to see whether it is temporary or whether it is stress induced, or retrograde ejaculation, wherein you examine the urine for the presence of sperm. This is how semen analysis has changed from 1999 to 2010 of what we follow now. The most important thing is the morphology, which was initially taken as more than 30% normal, has come down to Kruger's strict criteria of 4%. Even the motility of the sperm, which was initially more than 25 and 50%, has now reduced to just 32%. So what were the drawbacks of this system? Basically, there's no systematic review of the fertile population. The morphology which was done by using very different criteria. Then single semen specimen of each individual was taken, and the female age and fertility was not taken into account. Coming down to the count, it is very important to classify it as normal of more than 15 million per ml, oligozoospermia, and then azoospermia, wherein you see no sperm. So what are the various causes of oligozoospermia now? Idiopathic is the most common cause. Then there are other causes like infection, hormone disorders, varicocele. It could either be unilateral or bilateral. Ejaculatory dysfunctions, undescended testes, medical diseases, stress, drug use or drug overuse. Genetic is most important to always rule out Y chromosomal deletions. Whenever you have a sample of oligoasthenoteratozoospermia, it is always important to grade it. Why? Because the treatment options for mild, moderate and severe are different. As in mild, you see 10 to 15 million count, IUI can still be an option. In moderate, IVF with a double density gradient media can be done. And in severe cases, only ICSI remains to be a good option. Coming down to motility now, motility is nothing but the ability of the sperm to move. It could be rapid progressive, slow progressive and non-progressive. Normal motility is taken as more than 32% of progressive motility. Now what do you do for non-motile sperm? Whenever you see non-motile sperm, before labeling them as non-motile, always distinguish them from dead sperms. The simple value behind this is live sperms are always viable. You just have to stain them with a simple eosine nigrosine stain. An intact membrane never takes the stain, which is there in viable sperms. So whenever the sperm is stained, so it is a red color which you see, that is a non-viable and a dead sperm. Coming down to medical therapy for male infertility, there are a lot of options from clomiphene citrate, which is given at least for 2 to 2.5 months, to letrozole, 2.5 mg daily orally at least for 74 days. The other therapy is in the form of gonadotropins, which is very helpful in male with hypogonadotropic hypogonadism. You can either use injection HCG twice to thrice a week to even RFSH, but then RFSH becomes a very costly affair. Coming down to varicocele, initially it was seen just in 15% of normal population. Now it has risen to about 35 to 40%. It is seen in 70% cases of secondary infertility. The higher incidence of varicocele in men with secondary infertility is just because it's a progressive disease, and you have to understand that it affects the testicular dysfunction by involving both the spermatogenesis and steroidogenesis. There are several theories as to how varicocele affects male subfertility, is either by inducing hypoxia, autoimmunity, elevated testicular temperatures, there's reflux of catecholamine, but however none of them can completely explain as to what the exact cause is. But recently the oxidative stress theory has emerged as an important contributory factor due to the association between elevated reactive oxygen species and impaired sperm function in male. This evidence is also supported by the current guidelines which are issued by American Urological Association and European Association of Urology, where they state that varicocele treatment should be offered to a male partner of infertile couples who present with clinical varicocele and semen parameters are altered. Open, non-microsurgical, laparoscopic or varicocelectomy. So what are the best options? The best option would always be a microsurgical varicocelectomy, which is the most effective and the less morbid method. And hence, because all these oxidations have come, the test of DNA fragmentation test has risen. It is, what is DFI? It is nothing but separation of breaking of DNA strands, which you detect by the DNA fragmentation index. There are either a single-stranded breaks which are always repaired and they are always reversible, which is caused by exogenous factors. We have to remember that double-stranded breaks are due to endogenous reasons, and these can never be repaired by any amount of antioxidants given. So these are the various causes of sperm DNA fragmentation resulting from pathological factors like fever, varicocele, to genetic disorders which are the endogenous causes. There are several assays which are commercially available to do DNA fragmentation index. 2-3 important things to remember are, even in a normal semen sample, you can get a high DNA fragmentation index. So it has to be related clinically. Tunnel or SCSA is better than rest. The reference ranges are various for different tests. Generally, more than 35% of fragmentation, the patient is directly taken up for ART. So these are the various causes. So why should you be worried about all this high fragmentation? What does it actually cause? It may cause cleavage arrest in your embryo, multiple IVF ICSI cycle failures, there could be implantation failures and recurrent pregnancy losses. You generally come across such patients when you have normal semen parameters, the endometrium looks good, the embryos were good, still they didn't implant. So it could be a reason wherein the male partner would have a high DFI. Coming down to the antioxidants in male infertility. So which antioxidants to use, when to use, why to use, how long to use. So there are huge number of antioxidants in n number of combinations which are available. But finally the gist is, whichever antioxidant you use it just for 3 months. Till date there is no evidence as to...
Madam, could you please summarize? We are already running short of time.
1 minute. So there is no evidence which says that which specific combination is better than the other. No one drug is superior than the rest. So these are the various antioxidants. They've basically found that when you do ICSI in cases of sperm DNA damage, it has an improvement when the patient was on oral antioxidant treatment. Though there's no difference in fertilization or cleavage rate by using oral antioxidants in male, there's definitely a marked improvement of clinical pregnancy. So these are the various studies. Basically, they downstage or shift the level of ART, which is needed to bypass male factor infertility. Then to bypass the DFI, there's a pixie dish, which is nothing but based on hyaluron acid binding test, wherein the sperm binds to hyaluron acid and you could choose this best sperm. The other test is microfluidics, which also reduces DNA fragmentation index to the tune of 5%. There's no staining of fluorescent microscopy, which is required. I think at the end of all this, still we do not know which sperm would be the best to give you the best embryo and finally a clinical pregnancy. Thank you so much.
Thank you, Dr.